If we talk about psychoneurodevelopment, I think it's very important to be aware that pregnancy and the first 3 years of life are periods of enormous development. They're very critical, and it's also important to realize that development actually continues well into the 3rd decade of life. I mean, it probably continues more, we're developing all the time. But we used to think that in terms of the brain, that once a child was 12, 13, everything's developed. But in fact, that's not true. And a large part of development, particularly in the frontal lobes, occurs between the ages of 13 and 25. And for me, that's quite a positive thing, because it kind of opens things up, and one begins to realize that there's actually potential for change and intervention, for quite a while, whereas before we might have felt, if things are not sorted out by the time the child's a teenager, then it's too late. What are the fundamental requirements for healthy development? And I've divided them into 3. So good physical health and sufficient nutrition obviously are critical. Opportunities for sensory motor and intellectual stimulation, and then what I've called emotional nutrition. And these are all fundamentally important, and they're all very much interlinked, and they all play a role both in physical and mental development. So if we look at physical health, what is needed is the absence of medical conditions that interfere with growth and development, and particular conditions that affect the central nervous system, and sufficient nutrition to allow healthy growth and development. In terms of stimulation, the infant and child needs exposure to a variety of stimuli from the environment to promote healthy neurodevelopment, opportunities for sensory experiences, opportunities for motor activity, intellectual stimulation, and modeling, engagement, and interaction for language development. In terms of what I've called emotional nutrition, children need a safe environment. They need a responsive, reliable, and consistent caregiver. And they also need a supportive extended group of surrogate caregivers when the primary caregiver is absent. I like Piaget's stages of cognitive development in terms of understanding how the brain develops and how cognitive abilities develop. And you can see it's divided into stages, and I'm sure many of you are familiar with this. But just to remind ourselves that the first 2 years, what he calls the sensorimotor stage, really focus on motor development to a great extent, as well as the development of object permanence, which is the child's ability to understand that even if the child can't see something, that it's still there. And obviously this relates very significantly to their primary caregiver. In the pre-operational stage, which is from 2 to 7 years of age, so that pre-primary stage, the major areas of development are in language, memory, and the development of imagination and the use of fantasy. Primary school years, he calls the period of concrete operations. So this is the development of inductive reasoning, being able to reason things out from things that are concretely present in the environment. So very often primary school education will use concrete objects to be able to teach the child to reason. And the child develops the use of symbols related to concrete objects. But it's only from adolescence into early adulthood that deductive scientific reasoning and the abstraction really develops. So that's just a very brief picture of how the brain develops cognitively. The other theorist that I like in terms of psychological development is Erik Erikson, and one of the reasons I like him is because he's gone right through the whole lifespan. And he has divided stages of psychosocial development using terms with their kind of opposites. So talking about the first 2 years, there's a crisis that needs to be resolved, and the crisis is the development of trust versus mistrust. So that is a fundamental ability that infants and young toddlers need to develop, and it's the foundation for the rest of psychosocial development, is the ability to have a sense of trust in others and in the world, and if one's not able to negotiate that crisis, how much mistrust is left. So that's a very critical time, which I'll talk a little bit more about. And then around 2 to 4 years, the ability of the child to develop a sense of autonomy, that they are a competent individual that's able to relate in the world in a confident manner, as opposed to being filled with shame and self-doubt. That pre-primary period, 4 to 5 years, he said the crisis was developing an ability to have initiative as opposed to feeling guilty. And then the primary school years, the crisis is industry versus inferiority. So during those primary school years, where there's that significant period of cognitive development, that helps for the child to develop the sense of industry as opposed to not coping and being left with a feeling of inferiority, which obviously impacts on self-esteem. We all know about the adolescent years, and that the main issue in those years is to develop a sense of one's identity versus a confusion in terms of what my role is in life, what my purpose is in life. And then in the young adult years, it's about relationships, it's around intimacy versus isolation. And when you get into middle adult years, where most people are focusing on work, careers, building families, the crisis is generativity versus stagnation. And then in a normal lifespan, when you are ready for retirement or scaling down a bit, it's that sense of, you know, there's a life that's been well lived, or there's regret and despair. Okay, so obviously this is very categorical, and we all have different journeys, but I think that gives us sort of a paradigm, a framework around which one can understand psychological development. So just talking a little bit more about this first quite critical period in terms of understanding the psychology of infants and young toddlers, is that it's thought that the newborn infant is quite egocentric and doesn't really have boundaries between self and others. It's all me. And as a result of their physical and emotional needs being met, the infant learns to trust. The infant also begins to explore the environment, and through that begins to develop a sense of self and other. And through repeated short absences and return of their primary caregiver in a consistent manner, the child eventually over time learns to hold an internal picture of the caregiver, which would relate to that period of cognitive development where there's the development of object permanence. I also just want to talk a little bit about attachment, because this is a very important part of child mental health, and obviously the implications go on into adulthood as well. And to talk about attachment versus bonding, because I think a lot of people know about bonding, and did you bond with your baby? So bonding refers more to the feeling in the primary caregiver, mostly the mother, and their ability to form a relationship with the infant. Attachment refers to the infant's experience of becoming attached to a caregiver. So they're opposite sides of the coin. In the theory around attachment, it is said that an infant needs to form an attachment to a primary caregiver in order for emotional development to occur. And it's felt that these first 2 to 3 years are critical, and that there are various things that can disrupt attachment. And some of those are, if there isn't one primary caregiver, for example, in the case of very young children that are in institutions. The other that's thought to also disrupt attachment is where caregivers change. So the primary caregiver changes. Multiple sequential caregivers can also disrupt attachment. But I think that, given that not all children are in contexts where there's a primary caregiver, where there's the loss of a primary caregiver, one of the things that I think is really important is that it's also the quality and consistency of caregiving that's very important. So when attachment is disrupted, we talk about various types of attachment disorders. So, and a sort of a broad term is an insecure attachment. So it hasn't fully developed. Anxious attachment is where the child has a lot of anxiety about whether this caregiver is going to meet their needs and be available and consistent. And where attachment has not developed, there's been a failure to develop attachment, then we talk about, this is rather at the extreme, because it's obviously a spectrum of attachment disorder, of a reactive attachment disorder, where the child has failed to develop an attachment to anyone. And there are two types. So there's the inhibited type, where there's complete withdrawal and inability to make relationships or to work at developing relationships. And then there's the disinhibited type, where the child will just go to anybody. And actually the attachments that are formed are very superficial from the point of view of the child. But they're very happy to go and engage with people. I think another aspect that is very relevant in this field is the issue of childhood adversity, and you can't really see that at the top, but childhood adversity and mental disorders. So adversity is defined as a negative environmental influence that is present post-conception, so from the time of conception onwards. And the types of childhood adversity that have been studied include prenatal substance exposure. So it's any environmental influence. Could be physical or could be psychological. What has been found is that childhood adversity disrupts the stress response from an early age and increases cortisol reactivity. And what's also been found is that when there are sustained levels of increased cortisol circulating in the body and into the brain, it actually causes damage to cells in the corpus callosum and in the hippocampus. And we know that the hippocampus is the seat of our emotional development in the temporal lobes. So HPA axis function is very important and is influenced by gene-environment interactions. And early life environmental adversity can have long-lasting effects, and these are apparent from infancy. And these pathological stress responses are implicated in numerous mental disorders, including in particular anxiety and depression. So what has been found later in life is that anxiety disorders are associated with a diminished cortisol response, whereas depressive disorders are associated with high levels of cortisol with a failure to suppress the cortisol. And what's also been suggested by some of the studies that have been done is that cortisol reactivity could be normalized by intervention programs, which include medication and psychosocial interventions. So having that background in terms of development and what needs to happen to go right and what can go wrong, let's look at what are the risks are with HIV infection. So obviously there's a virus which the child is exposed to intrauterine and possibly postnatally, which impacts on the central nervous system. There are also opportunistic conditions that affect the central nervous system. Maternal substance abuse, which may commonly co-occur with HIV infection, also has an impact. The medications that are used to treat HIV and other conditions, some of them have neurotoxic side effects. And this is all in the background of possible poor nutrition due to poverty, difficulties around breastfeeding, and possible maternal depression. There may be a failure of adequate stimulation due to poor physical health of the infant or child, and or poor physical or mental health of the caregiver, and a failure to provide sufficient emotional nutrition because of poor physical or mental health of caregivers, perhaps the death of parents, orphanhood, and institutionalization. If we look at the brain and development in a child in the context of heart, in the international literature, it shows that there's been a significant decrease in HIV encephalopathy. And the reduction in mortality in high-income countries has been significant. However, it's noted that morbidity has not decreased to the same extent. And in low and middle income countries, children are still dying, still developing HIV encephalopathy, and there's significant morbidity. The other thing that's of interest is that perinatal infection versus exposure to HIV and exposure to art is still being investigated. What impact does exposure to the virus, even though you don't become infected with it intrauterine, what impact does that have on cognitive development? Generally, what's been found in the literature is that up until recently, infants with and children with HIV infection very often have very high pre-treatment viral loads, and it's suggested that that has a significant impact on the brain. Also, with treatment in children, there are different HIV dynamics from adults, so there's a slower decrease in viral load. Obviously, also there's a higher risk of drug resistance due to inadequate adherence. The child's dependent on caregivers to provide the treatment, and we all know that there are huge issues around adolescents with adherence. And then over time, multiple treatment regimens. And as we progress in terms of providing treatment, there may actually be perinatal transmission of drug-resistant strains of HIV, which then make it more difficult to treat. So cognitive impairment in perinatally infected children with HIV, some of the factors involved are the actual effects of the HIV infection. So there may actually be ongoing CNS viral replication, even in the context of heart, as well as the past impact of infection, depending on when you start the treatment. So there may be chronic inflammation in the brain. There may be drug toxicity from the antiretrovirals. There are obviously social factors, and then other exposures, as I've mentioned, both in utero and behaviorally based, such as substance use. So there's the HIV encephalopathy, which is like the most severe end stage of brain HIV infection. But there's a whole spectrum of cognitive impairment, from very subtle signs to more significant signs. And what has been found as early signs of cognitive impairment are impacts on executive functioning and processing speed. And these are all functions which are located in the frontal lobe and in the subcortical areas between the frontal lobe and the temporal lobe. So executive function is your ability to plan and organize your life, and it requires attention. And some of those early signs, if one does neuropsychological testing, that are impaired would be the difficulty with attentional flexibility, the ability to attend to something and then move to something else at an appropriate time, and visuospatial working memory. And working memory is the memory that you use to learn, so that you take information in, you process it, you work it out, you lay down long-term memory. So that is impacted in children. And then processing speed is the speed at which you process and do things. And those of you that work with adults will know that one of the very early signs of HAND, HIV-associated neurocognitive disorder in adults, is slowing. It's one of the very early signs that you can see in someone with HIV dementia is that psychomotor slowing. ADHD, the next speaker is going to speak about ADHD, so I'm not going to speak a lot about it, but it really does seem to be a fundamental aspect of the neurocognitive impairment in children with HIV. And then other people have found poor language ability in adolescents, both those infected and those exposed. And then obviously at the other end of the spectrum, there's the global intellectual disability, which can be of varying degrees. There's quite a bit of work being done at the moment, some research studies coming through looking at the cognitive aspects of those that are infected and those that are exposed in South Africa, but there isn't much in the literature at the moment. What's been found is that the more severe the disease, the more permanent damage, and that's also the same in adults, but obviously it's more critical in children because of the disadvantage that it gives them. And what's protective is having a higher CD4 count at the initiation of treatment and a longer treatment duration. So the current recommendations for treating children with HIV, infants, is to start treatment early, irrespective of the stage or the biomarkers. So I think there's been a greater understanding that HIV affects the brain from very early on, and it has an impact. And presenting with HIV encephalopathy or HIV dementia is a very late sign of the damage that's going on in the brain. And the treatment is antiretroviral treatment. So you should start treatment early to prevent permanent damage. The other thing is that educational interventions are needed on a significant scale. And Renee Nasson, who's a child psychiatrist in Cape Town, who's done a lot of work with pediatric HIV, she's suggesting the use of an educational register for children that are HIV infected to ensure that their educational needs are being met. So obviously there's aspects about that that are controversial, but the concern is that in our education system that these children's needs are not being met. Okay, so in terms of the management, it's treating the HIV and other medical conditions. It's providing psychoeducation to parents and caregivers with respect to appropriate expectations about this child's development, appropriate educational placement and social support, and then medication, psychiatric medication, does play a role in terms of treating the ADHD and associated disorders such as disruptive behavior disorders, anxiety, or mood disorders. Okay, so we've looked at the neurocognitive aspects. Now I'm going to move on to the psychological issues and the psychiatric aspects. And these are some of the issues that children who are infected with HIV, as well as those who are unexposed, have to deal with. They have to deal with parental illness and possible death and bereavement. They have to adjust to surrogate care in some cases. They have to deal with disclosure, what impact disclosure of their HIV status has on family, friends, relationships, future partners. And we know about the huge impact of stigma around HIV infection and the shame that goes with that. They often have difficulty progressing at school, and that impacts on their self-esteem, as I mentioned before, this feeling that you can do things and you're capable, as opposed to I'm struggling and I'm not coping. They have to deal with having a chronic illness and adherence to lifelong medication, and sometimes they also have to deal with failing regimens and facing death. If we look at the literature on psychiatric disorders in perinatally infected children, some studies suggest that it's the same prevalence of disorder as in children with other chronic life-threatening diseases. Others suggest that with HIV, it's higher because it's HIV. There is this increasing interest in those who are exposed but uninfected. Most of the literature is from developed countries. There's very little from low and middle income countries. And obviously those are small numbers of children, generally from disadvantaged communities. And they look at both infected and affected children, and the affected children are often orphans. There's very little literature from South Africa. And bear in mind that we have much larger numbers, so it's a bigger problem for us. And I don't think that we can entirely extrapolate from developed countries in terms of what kind of prevalence or problems our children might be experiencing. So what are the common problems? This was an early study by Sharko in the United States, showing about a quarter of children experiencing problems with ADHD, depression, or anxiety. Other common problems that would occur in this context are substance use disorders, behavioral problems such as oppositional defiant and conduct disorders, and then the attachment disorders that I spoke about earlier. This was a study in the United States of children and primary caregivers. So they interviewed children and their primary caregivers and found intellectual disability in 25%. So about a quarter had intellectual disability, and 2/3 had a borderline average IQ. So there's a significant impact in this group of the virus on cognitive development. They found 14% had ADHD, 12% had a mood disorder, and only 2% had other disorders, including anxiety disorders. And I have some problems with those figures. But what was interesting was that they said that the majority of families were actually coping well. And I think that's important to remember, because we very often focus on where there are problems. And this study was saying that actually 75% were actually coping fine. Williams et al. In 2010 looked at substance use in adolescents and the associations with mental disorder and CD4 count, found that substance use was similar in those who are infected and exposed, and the associations of substance use were with ADHD, mood disorder, oppositional defiant disorder, conduct disorder, and having a low CD4 count. So I think having the low CD4 count is probably a consequence of the substance use, because we do know that substances accelerate disease progression. What's interesting, you can see, is that the risks when you have a behavioral disorder are particularly high, and when you have a mood disorder as well. That both the infected and exposed were affected, and that there should be programs to prevent substance use in both groups, particularly those with psychiatric symptoms. Another study, again, showed a similar prevalence in both these groups. So it's children in families affected by HIV, and it's similar in those who have the virus themselves and those who don't. What was interesting was that in this study, those who were infected had higher rates of special education, psychopharmacological and behavioral interventions than those who were not infected. And I think that's got to do with access to care. Another study which showed an overall prevalence in both groups of 29%. In this study, interestingly enough, those who had not been infected actually had a higher prevalence of mental disorder than those who were infected. And some of the characteristics or risk factors were caregiver related, where the caregiver has a psychiatric disorder, or they have problems with parenting, or they have functional limitations in terms of their health. And then child characteristics, younger children with lower IQ had more problems. Mellons is someone who's done quite a lot of work in child mental health in the context of HIV, and they've done a two-stage study where they looked at baseline 2009, and then 18 months later they followed up this group of children and adolescents in New York City. And then they tried to look at the associations between HIV infection and the mental health outcomes in this group of children. they found that the most prevalent diagnoses in both groups, again, they found quite similar prevalence in the infected and the exposed, significant prevalence, particularly of anxiety disorders. And I think that this anxiety disorders are very common, and we don't pick them up very easily, and we don't treat them. And treatment is very effective for anxiety disorders. And what they found in their study was at baseline, those who were infected had significantly higher rates of mental disorder than those who were uninfected. And that difference was largely attributable to ADHD. And I think that's because the ADHD it's a neurological consequence of the brain infection. Obviously, the mental disorder increased the risk of sexual risk behavior and substance use in both groups. And what was interesting was when they did the 18-month follow-up, those who were HIV infected, their prevalence of mental disorder had decreased. But those who were exposed but uninfected, their prevalence had increased, and this was largely due to an increase in the number of mood disorders. So again, I think this is around access to care, and it's saying in the United States context that those who are infected get access to care and access to mental health care, whereas those who are not, they're not in a treatment system and they're not accessing the care that they need. There was no association between biomarkers and mental disorder. And what the study suggests is that while there may be some factors associated with the infection, there are other factors in this group, people affected by HIV, young people affected, that are determinants of mental health. So it highlighted the critical need for mental health interventions for both groups and also advocated for family-based interventions. Try to look for literature from the developing world. There was a study in Thailand which looked at depressive symptoms in HIV-positive children and adolescents compared to matched controls who were HIV negative, and found lower rates of depressive symptoms in those who were infected. However, looking at a study in Zambia, here they didn't compare, but they found high rates of emotional and peer problems in a group of children who were HIV positive. They also found that disclosing their status did not have a negative effect on their mental health, and they suggested that interventions to promote disclosure could facilitate access to support for these children. Another study looked at attachment in mother-infant pairs with HIV in Uganda. So they looked at HIV-positive mothers, those with AIDS, and HIV-negative mothers. And they found there was no difference in the prevalence of insecure attachments between HIV-positive and HIV-negative mother-infant pairs in the same community. But infants of mothers with AIDS had more insecure attachment. And I think that, again, would make sense. If the mother's very ill, it's very difficult for her to meet the needs of her infant. Trying to look at what information there is from South Africa, there's very little. There are several studies on mental disorders in children affected by HIV. So orphans and vulnerable children, there's definitely an increased risk of distress. There's one small qualitative study of perinatally infected youth, which suggests that they may have more mental health problems, but there's no hard evidence from that. And then just generally looking at childhood adversity in South Africa, this study looked at a sample of young adults from 70 rural villages in the Eastern Cape, and this is the prevalence of childhood adversity in this quite large group of young adults that they had experienced during their childhood. So very high levels of physical punishment, very high levels of physical hardship, and that 66% versus 48% is females versus males. So females had more physical hardship. Quite significant levels of emotional abuse, emotional neglect, and sexual abuse, particularly in females. And then they looked at associations between childhood adversity and incident HIV infections, and these were associated with the abuse whether it was emotional, sexual, or physical abuse. And the odds ratios are there. Emotional neglect was associated in females with depression, suicidality, alcohol abuse, and incident HSV2 infection. And in males, it was associated with depression and drug use. So the conclusion is that childhood adversity is common in South Africa. So that's the background context, and is associated with adverse health outcomes, both physical and mental health outcomes. Then there's an interesting article by Skovdal, who says, are we pathologizing healthy children? Because there's all this literature coming out about how distressed children affected by HIV are, and we're not looking at those who are affected but are coping. And he suggests that studies of psychological distress make assumptions about childhood and about mental health without considering the social and cultural context of children in Africa. I think that's a rather controversial statement that we could perhaps discuss at length. But I think the point that he makes, that there are very few studies that explore interventions to increase resilience and support without engendering victimhood in children, is very important. And Janine is going to talk later about psychosocial support in the context of pediatric and adolescent HIV, and I think that I'm sure she will talk more about that. What I'm going to talk about now, and I've got very little time left, is how do you identify psychiatric disorders in children and adolescents? And people are very scared of getting into psychiatric assessments because they feel they don't know what to look for, and even if they find it, they don't know what to do. So I'm going to try and allay your anxiety around those issues and show that it's actually not that difficult. The main issue is the time that it takes. And I don't think there's any way of getting away from the fact that getting information about mental disorders takes time. I think, though, that one should also remember that your relationship with your patients is a very important aspect of helping them in terms of mental health and psychiatric issues, and in terms of identifying the problems. And I think it highlights the problems that we sometimes have in this country with continuity of care for chronic diseases. And it's something that I think that we should be advocating for, that there is continuity of care in this kind of context, because if you are seeing a family or a child or an adult over a period of time and you get to know them, over time you can begin to identify if there are psychiatric problems, even if you can't do it in one interview. We all have to make the best of the resources that we've got. So, you know, I thought just to give you an outline of the kinds of things that are important to think about, to ask about. And I'm not suggesting screening tools or anything like that, just using your clinical interaction and your clinical abilities when you are seeing patients. So when you want to find out about psychiatric disorders in children and adolescents, obviously you need to interview the child or the adolescent, but you also need information from other significant people, particularly parents or caregivers, and schools can be quite an important source of information. So if you can get school reports, that's helpful. If it's the actual school report that the parent can bring you, or certainly in our child mental health services, we have a structured form which we send to the school, which they send back, and which often provides very valuable information. And then your observations. Very important to observe the child or adolescent and get a sense of what their mental state is like when they're in the interview with you. And also, critically important, what is the mental state of their caregiver? And again, particularly with young children, but even with adolescents, what is the nature of the interaction between the caregiver and the child? And when you're doing your assessment, I think the sort of major groups of problems to think about are, is there neurocognitive impairment? Because then obviously there are a whole lot of interventions that need to follow from that. Is there intellectual disability? is there ADHD? Is there a mood or anxiety disorder? Is there a psychotic disorder? And then in terms of managing this, you would use a comprehensive biopsychosocial approach. When you interview children, it's preferable that very young children are seen with their caregiver, and because they feel more comfortable with that usually, but sometimes it may be useful to interview a child on their own, particularly if you have already a good relationship with the child. And you start with easy general questions, and then you move on to more difficult questions that you really want information about once you've established rapport with the child. With adolescents, it's really important to spend some time alone with them, because there are often things they want to tell you about that they don't want to talk about with their caregiver. And if you are going to interview the parent or caregiver, I think it's quite important that you do it in the presence of the adolescent. So there isn't this feeling that my parent or caregiver is talking about me and I don't know what they're saying about me. It's critical to engage adolescents in the process in a non-judgmental, empathic way, and also not to make promises that you can't keep. So there are limits to confidentiality. If an adolescent tells you something that indicates that there's a significant risk to someone else or to themselves, you would be bound in terms of their best interests or the best interests of the other person to disclose that information appropriately. What are the common presenting complaints that children with mental disorders have? And I think one of the most common in our country is failure to progress at school. That's the problem that parents come with. And there can be all sorts of reasons why a child is not progressing at school, not only because of their cognitive abilities. So there may be externalizing disorders such as ADHD, oppositional defiant disorder, conduct disorder, or internalizing disorders such as anxiety or depression. Another way that they may present is with disruptive behavior, because disruptive behavior disturbs other people. And again, disruptive behavior can be due to any of those conditions listed above, including anxiety or depression, because sometimes children present with disruptive behavior or difficult behavior when they're anxious or depressed. They may present, particularly adolescents, with suicide attempts, and then they may present with altered mental states due to intoxication, psychosis, manic episodes, seizures, or delirium. And I mean, usually those are pretty clear and not that difficult to identify what the problem is. I want to talk a little bit, though, about the internalizing disorders, because those are the ones that are often missed. And they don't often present with emotional symptoms. Children don't come and say, I'm depressed and I'm anxious, because they don't actually have the vocabulary or the conceptual understanding to say that. And so one needs to ask the child and the caregiver about various aspects which would point you towards saying that this child has an anxiety or depressive disorder. So mood changes from how the child or adolescent was before. More tearful, being withdrawn, loss of interest in their usual activities, loss of pleasure in things that should give them enjoyment, and irritability. Those may all be signs of depressed mood. There may be physical or psychological symptoms of anxiety. Pain, they may present with pain, particularly in many different areas of the body. And then things like palpitations, tremor, sweating, irrational fears. A common thing with young children is rejection sensitivity. You know, like they have a fight with their friends and they don't get over it, and it becomes a huge issue. Separation anxiety, enuresis, these may all be symptoms and signs of an underlying anxiety disorder. And then the neurovegetative features, sleep and appetite changes, changes in energy levels and concentration. I think the important thing when you're looking at an anxiety or mood disorder is that it's a significant change from the norm, from how the child usually is. Just some things about mood disorders. Depression often coexists with anxiety. It may present with a drop in academic performance or behavior problems. I just want to say a bit about bipolar mood disorder because it's uncommon. So it's not the kind of diagnosis that you make very easily in children. It may present for the first time in adolescence, and what's important in this context is that it may be secondary to or precipitated by general medical conditions, substance use, or medications. And I mean, if you suspect that a child has bipolar disorder, they really do need to be referred for a psychiatric assessment. Various types of anxiety disorders. So generalized anxiety disorder is very common. And this is pervasive symptoms of anxiety. Then there are other anxiety disorders that you may come across. So panic disorder, where there are acute episodes of anxiety. Post-traumatic stress disorder, where there's been a traumatic event, and they present with intrusive memories, hyperarousal, and avoidance. Obsessive-compulsive disorder can present in childhood, where they have irrational, intrusive thoughts, and then they perform rituals to reduce the anxiety that the thoughts create. And then there's social anxiety disorder, which is anxiety when you're interacting with other people or when you're having to stand in front of a whole lot of people and speak to them. Another group of disorders that I think is quite important to think about is adjustment disorders. So this is where there's been a psychosocial stress prior to the onset of the symptoms. So for example, if a parent has died. The child doesn't get over it as you would expect the child to, and may present with ongoing mood changes or anxiety or disturbances of conduct or a mixed picture which lasts more than a month. It's not as severe as a major depressive disorder. So their impairment, their functional impairment is not as severe, and their symptoms do not meet the criteria for a major depressive disorder. One could then talk about an adjustment disorder. And then also just talking about bereavement, which may present with all the features of a major depressive disorder, but generally these symptoms do not last more than a month. And the need for intervention in bereavement depends on the level of impairment or disruption. So how do you manage anxiety and mood disorders? Medication is a very important aspect, and we generally tend to use the SSRI antidepressants. Fluoxetine, which is available on the EDL, is registered for use from 12 years up. So if you're wanting to think that a younger child needs medication, then it is important to consult with a mental health professional. Or if your SSRI is not working, then one needs to look at other medications. Psychological interventions are critical, and that can range from support, addressing developmental issues appropriately, providing psychoeducation, to actually addressing specific disorders through various types of psychotherapy. And then obviously social interventions in terms of attention to educational needs or social and financial needs are very important. When one talks about managing disruptive behavior disorders, I'm not going to talk about ADHD because that's the next talk, but in terms of these other disorders, medications have a very limited role, and they really are used for symptomatic treatment. The main area of intervention is in psychological interventions, and one can use a range of interventions, therapies, and parent counseling and skills training. And then substance abuse rehabilitation can be a very important aspect here, educational and social services interventions. So ideally, we would want to treat children in a family-based approach. The advantages of using a family-based approach where you treat everybody in the family who's infected and affected is that there are less secrets, there's less stigma, and there's better communication. There are also opportunities for preventing mental disorders in children through treating maternal depression and promoting healthy attachment, providing psychoeducation to parents and caregivers, dealing with developmental issues before and as they arise, and empowering parents and caregivers to provide quality care for their children. Again, if you have a family-based approach and you have a multidisciplinary team, you can provide comprehensive care, which can include all these things that I've mentioned. And then a one-stop service is ideal. So it would be really nice to have these centers of excellence where you're treating kids with HIV, those affected, in a family context with a multidisciplinary team. But in our South African context, with the lack of resources, at the moment this is a pipe dream. So I think in place of that, what is really important is to establish links with local child and adolescent mental health professionals and services in your area, and have good communication channels. And that's it.